He's a public health physician who currently serves as Chief Medical Officer with the First Nations Health Authority, where he leads a team of physicians focused on First Nation health and wellness in BC and represent the First Nations Health Authority on public health matters. He played a key role in the First Nations Health Authority's work to create a unique and improved healthcare model in BC for First Nations people, one that will be the first of its kind in Canada. Dr. Adams previously served as BC's Deputy Provincial Health Officer, where he provided independent direction on First Nations and Aboriginal health issues to the Ministry of Health, reported to citizens on health issues affecting the general population, and set out a path for the improvement of First Nations and Aboriginal health and wellness. He has also served as the Director of UBC's Division of Aboriginal People's Health. Dr. Adams completed his MD at the University of Calgary, his Aboriginal family practice residency at St. Paul's Hospital, UBC, as Chief Resident, and his Master's of Public Health from Johns Hopkins University. Dr. Adams is also you may have recognized him because he also has an acting career. He was in the feature film Smoke Signals, which is actually playing in town tonight at 6:30. So I invite you to maybe go see this movie at the Pacific Cinematheque at 6:30 tonight. What a coincidence. So I welcome Dr. Adams.
Gosh, I'm really pleased to present to you today. I'm pleased. I don't often speak to the general public. I usually speak to health professionals, but there are a couple of reasons I wanted to be here. One of them is I consider you my tribe, and I would really like to speak to you about the work that I do. The other is that I think gay, lesbian, bi, trans, two-spirited, queer communities are very good at diversity. So I'm really happy to talk about diversity because first of all, I think that you understand it well, and I think for Aboriginal communities, we don't necessarily have intuitive allies who understand the other perspective, other in quotation marks. So there are a number of ideas I'd like to leave with you. I'm presuming that many of you work in health. I'm presuming that many of you work in support of our communities, that you try and keep your fellow gay, lesbian, bi, trans, queer, two-spirited neighbor well. And what does that look like? I know as well that probably some of you who are healthcare workers are involved in developing health planning at a provincial level, in that we are trying to come together in our diverse communities to look at health planning and what that might look like from a provincial perspective, i.e. if the provincial government was invested in us as a group, as a hard-to-reach population, as a part of the BC population, what would that planning look like? My job today, though, really is to describe Indigenous health from an Indigenous lens as an Indigenous person, but also as someone who works in health. So my name is Tlesla. I'm from Sliman First Nation, which is about 200 kilometers from here as the crow flies. It's very, very close by, and this isn't my territory, but it's very, very close. And I think we live in a beautiful place, and I'm always very thankful for the city of Vancouver. I came here about 30 years ago, and I do like it here very much. I'm the Chief Medical Officer at the First Nations Health Authority. The First Nations Health Authority is 25 months old. It's the newest health authority. Of course, there are 7 health authorities in the province of BC. We're the 7th and the newest. And I'm the Chief Medical Officer there, which means I'm a public health official. So, our vision at the First Nations Health Authority, which is a First Nations health service organization tasked with looking after First Nations people in the province of BC. There are about 250,000 Indigenous people in this province, and we help to care for them. Our vision is healthy, self-determining, and vibrant BC First Nations children, families, and communities. And I put pictures here of my different families. I'm very lucky in that when I came out, my family kept me around, and I stayed with them, and we're very loyal to each other. And I now have more families, as in I have 4 biological sons with 2 lesbian couples. I'm also married, and my husband has 2 children of his own. So together we have 6 children, and here are some of them. And when I was a young gay man, I really didn't think about having children or being the head of a family or a part of a family that, where I wasn't the youngest and most junior member. That's something that was new, and it's something that I negotiated with other queer people. How does that look? That was new to us. What would happen, for instance, in the event of our deaths? Where would our children go? Who would make decisions around our children's education? Whether they were circumcised or not. Like, how did we negotiate that? And how would adoption work if there were 2 dads and 2 moms? How does that fit into our idea of family? The First Nations Health Authority, though, much like, say, South Africa, when it was looking at issues of racial equality or equality amongst the citizens, was very quick to embrace gay, lesbian, bi, trans, two-spiritedness, the concept of equality. And they wrestle with it, we wrestle with it as a country in Canada, and we wrestle with it as First Nations people. What is equality if we're apples and oranges? If my family looks different than other First Nations families, how do we fit into the scheme of things? But definitely the First Nations Health Authority gives very clear signals that we include all kinds of familial configurations, and we include two-spirited people in our health planning. Social stigma is not a concept that I really need to review with you. I think you all know it very well. Extreme disapproval, including bullying and ostracization by people or groups towards people or by groups who differ from their expected cultural norms. And I mean this from a sexual orientation or a sexual identity perspective, but also from a racialized or ethnic perspective. I find it to be a very odd posture whenever I encounter it, and as someone who's around and about a lot, I do encounter it regularly, but only from a very tiny percentage of the population. And I was lucky to grow up in a family where I was taught what I call resilience, as in I should expect that someone will oppose, maybe even object to me being there, and I must stand up for myself. So stigma begets a response of resistance and resilience. Sorry for the mistake in the translation of my PowerPoint slide from its previous version to this one, but it says pride through resistance and resilience. I came out in 1984. I was 18. My best friend was a lesbian, and she helped me out. She came out the month before me. In 1984, Gaëtan Dugas had just died in Quebec City, and he was all over the news. HIV and its newness was all over the news. I came out to my family in 1985. I had a very tough father. He didn't raise me with a gentle hand at all. I thought he might beat me up and kick me out. So I was prepared to leave, even though I loved my family very much, my 4 sisters and my brother. But my father said, "Yeah, I thought so." And I said, "Yeah, and Dad, being out is not just me being out to myself and being out to you. It means being out in public, as in your friends are going to hear that I'm gay." And he said, "I'm not worried about that. No one's going to say anything about you in front of me." Which was really great, which was really wonderful. Instead of him being embarrassed and saying, "I'd rather keep my religion than you," he said, "Yeah, I dare them to say something about you in front of me." And I believed him that he would defend me, and that really emboldened me to be out. And I've always been out since I was a teenager. I moved to Vancouver in '86 to work at Expo '86. And I was out at work. I was an actor. It wasn't a big deal, honestly. What was happening at the time, though, was that a lot of gay male actors, and there were a lot of them, then a lot of them were contracting HIV and passing away, and there wasn't this handoff. Actors who were mid-career or some who were older were saying to me, the gay actor is a strong tradition. We used to look after each other and help each other out in the theater, but so many of us are gone or we're sick, and that handoff isn't happening. And certainly as a young actor, I could feel that there weren't older gay men to help me along. I had to make it on my own a lot at that point. But it was a really fun time at the same time. And I think any of the gay men who were here in the '80s, it was a difficult and painful time, but also a very exciting time as well. And my first boyfriend, when I was 19, had HIV. And so I was in the thick of gay men's culture. And it was very interesting to try and get one's head around this new reality. Well, I call it a new reality, but actually, maybe from my point of view, it was an old reality. The idea of two-spiritedness is that two-spirited people are native people who feel their body houses both a masculine and a feminine spirit. And it comes from traditional beliefs, like from the Lakota or the Navajos. But it is a belief that's relatively new and that we've reincorporated into a modern identity. How does it fit into the modern day? As in, I can't live as an Indigenous woman from last century and an Indigenous man from last century at the same time. I really have a new way of living, and so how do I incorporate the ideas of masculinity and femininity into the modern? And my father had a very firm idea of what an Indigenous man should know, which meant having Indigenous knowledge that a man could survive within his territory. It meant that my father would pull me out of school so I could go on the land and I could hunt and fish and be strong, and I physically trained so I could do all of those things that a man, an Indigenous man, a man would need to survive. My father had married my mother. They met in residential school. My mother had spent her life in residential school from when she was 3. My father went when he was a teenager. He didn't learn English until he was a teenager. And I think part of the reason they formed such a successful partnership, they're still married today after 65 years, was that she could read and write and she could function in a modern society, and he could function in our territory. He could hunt and fish. And when they married, he asked her to cook him fish head soup, which is really a boiled fish head, but she didn't know that you had to take the gills out. And to my father's family in our community, they thought, what's wrong with her? She's so dumb. You know, she's lived away from us for so long. She doesn't even have basic knowledge. My father really didn't want that for us, so he constantly pulled me from school so we could be in our territory. One of the other things that we would do is we would go and visit elders. Luckily, I'm from a culture that is not sexophobic at all. In fact, I think probably the opposite. It's very sensible, as in we're taught that all of us are sexual by design. We're meant to have sex. It's part of our biological imperative and biological function. We're not fearful of it. We don't have a Christian basis traditionally where we steer free of it. And so it was very easy for my father to, and eventually my mother. I remember my mother saying to me when I came out, she said, well, you know, the Pope says you must abstain. It's okay to be gay, but you must abstain. And I took that in and I thought, okay, I must be tolerant of her Catholic convictions. And then we both started laughing. We laughed ourselves silly. And then she said, and my God, what do you do in bed? I can't even imagine what two men would do in bed. And I said, well, I've just come out to you. That's about all I can do today. I don't really want to start talking about what men do in bed. And she said, no, really, I'd like to know. Would it help if I told you what me and your dad do in bed? And I said, no, really. I really don't want to know. And I won't tell you what my dad said. Well, I'll tell you, okay, because we're friends. But please don't quote me anywhere. He says, oh, for Christ's sake, Janie, he likes it up the bum. And that was the end of our discussion. I still have to clarify that with him. Maybe not. So, sexual stigma, sexophobic attitudes, really very interesting. You've probably heard a lot about it today. But I do want to go back. This is my slide to say, let's go back in time. This is my great-grandfather. His name was Atam, or Charlie Adams. He was born in 1870. This is a photo of him when he was, he was born in 1860. He was 70 years old when this photo was taken in 1930. He was dementing and admitted to hospital in 1930. They took a picture of him on admission. They noted that he was blind, which I had heard. He was blind his whole life. And he was a woodcutter. His daughters would take him into the bush and he would cut whatever he could feel. And even in the 1911 and 1921 censuses, he was listed as woodcutter. But, so I knew that he was blind. It was interesting to find a photo of him and to find the doctor's notes on his admission. And they noted that he was scarred from head to toe. And I thought, oh, that's odd. Was someone beating on him? And then I remembered that if he was born in 1860, the smallpox plague that decimated BC First Nations happened from 1862 until 1870. And that smallpox kills a third of the people that it infects. Usually in First Nations populations, probably even higher than that. But it blinds 10% of that population. And so he's almost certainly a survivor of smallpox epidemic. And so this idea of pandemic, certainly within my family, was a very old one. And what do you do? I had an elder who hadn't gone to residential school. Her mother kept her out of school. The law of the time was that when your children became school age, they would be removed from you and institutionalized in residential schools. And this woman's mother said, "The Creator gave me children to raise. I don't like the idea of anyone doing it for me." And they went on the run, which meant that you just didn't live on reserve, and you went in the bush and you followed the food, usually in the wintertime, and you stayed away from the Indian agent who would, remove your children from you. And so I asked her, I said, "What was it like? What was your life like without school?" And she said, and this is verbatim, she said, "We had nothing to do. We had nothing to do but help the people." Her early education was about working with elders and working with families. She'd be sent out as a little girl and to do whatever needed doing. If it was to haul water, if it was to wash things, if it was to mind children, even difficult things, she said, like if a baby was being born, she would go and help, even though she had no idea what to do and no idea what was happening. She would stand by, and that was her learning. And this was very interesting to me later on when I became a doctor, and I was telling her about being in Emerge, telling her how important I was as the young resident physician. I was saying to her, "Can you imagine how busy we were in Emerge? We had not just one chest pain, but 2 chest pains. We had someone having a stroke. There was a motor vehicle accident with 3 people who were injured waiting for assessment. And then this old lady with diarrhea tells me, can you get me a glass of water?" Can you imagine? I was so busy and she wanted me to get her water. And my elder said, "Oh, maybe she thought you were there to help." This is my family, my parents and my 4 sisters and me. My little brother hasn't been born yet. When I was 8 years old, my sister Janice, who is the third eldest, the third eldest, you see her there between my mother and my eldest sister, she was accidentally shot and she died. And even as a little boy growing up on a reserve, I knew that communities should be organized enough that boys shouldn't be allowed to play with guns, and that an ambulance should arrive quickly, and that there should be people to help when a child is bleeding and dying, and that when my parents were recovering, that they should have had help. That we should be organized enough as a society, even our little tiny reserve of several families, should be organized enough to offer each other help. And that has stuck with me, and it's no surprise that all of my siblings, we now work in helping professions, and definitely my work is about organizing health services so that when bad things happen, we can react. And in fact, the concept of wellness, or the idea of services, should actually be larger than stepping in when you're profoundly hurt. Maybe health services should support you in your wellness and help you protect your wellness. Maybe it can actually be a big part of your life, and that we, as gay people in a neighborhood, could help each other with our wellness instead of just stepping in when you're close to death. So who are Indigenous people? The concept of indigeneity to me is not a difficult concept in the slightest, even though we wrestle with it as a country. There are about 400 million Indigenous people living in over 70 countries worldwide, including, of course, the US and Canada, but also Australia, New Zealand, Polynesia, the Americas, really, in Panama, Guatemala, Ecuador, Bolivia, Chile, but also in Africa, in Rwanda and Burundi, in the Congo, and all over Asia. In fact, Antarctica is the only place where there aren't original peoples. And the lot of most of these original indigenous peoples is that they're moved aside to make way for waves of migration. And migration I don't think of as a bad word. We're not barnacles, we have legs, we move about. And so original peoples are moved for newcomers. And having been to a beautiful place, say like Hawaii, I understand why people would go there. And if I were to go there, I would try and respect the local custom and to see what's there for me. It's not a bad idea. However, for Indigenous people in many countries, their losses to make way for migration are considerable. They literally can become the poorest and most marginalized populations in their original territories, and that's certainly the case for Aboriginal people in Canada. We have the worst outcomes of any ethnic group in the country. Another thing that's very important about Indigenous populations, certainly in Canada, and this is probably true for most Indigenous peoples in other parts of the world, is that we're non-dominant. As in, there are other dominant forces on us, that self-determination at a personal level, the ability of a person to chart their own course without interference from other individuals, is not respected. And at a political level, self-determination, the right of a nation to determine its own course without interference from other nations, isn't necessarily alive and well. And so there are other forces that shape their lives. For instance, residential school, when you're not allowed to raise your own children and your children are removed and institutionalized. And thank goodness we've stopped that barbaric practice. And as many of you know, like when I was in school in the 80s, I remember a young man who was very bright. When a few of us were talking and a few of us were out, he was shocked. He was from a Latin American country. And even though he was a very bright scholar, he said, "My God, in my country, we beat gay men up." And of course, we all yelled at him and said, "That's ridiculous." But in his worldview, that's what happened to gay people. And we still hear that sentiment a lot, that kind of behavior is normalized. And thank goodness, I hope, in our day-to-day, we rarely encounter that kind of thought process. So what we know about Aboriginal people is already very well documented. This is from the Royal Commission on Aboriginal Peoples from the 90s. Aboriginal people are at the bottom of almost every available index of socioeconomic well-being, including educational levels, employment opportunities, housing conditions, incomes, et cetera, et cetera. And we have the worst outcomes of any ethnic group, literally any ethnic group. And this has to be somewhat by design. It's not completely an accident. We used to have everything, and now we have the least of anyone. However, the Royal Commission's report was used in a custody battle. It was quoted in a custody battle between an Aboriginal and a non-Aboriginal parent. The non-Aboriginal parent's lawyer argued that the Royal Commission tells us that Aboriginal communities are unfit places for children to live, and thus you must award custody of the child to the non-Aboriginal parent. And it reminds us that defining Indigenous people by their deficits is a disservice, that it's only a partial truth that doesn't serve. And that the other side of the story, which is why I'm telling you so many personal stories of strength and beauty, is that when we are reductionist, and we say Indigenous people, or gay, lesbian, bi, trans people, are the poor second cousins of other Canadians, it tarnishes us and it misplaces us. And we must talk about our strengths, and we must tell the truth, and we must be able to fill in the complexity of our lives to others. We must speak up. This is an island in my territory. It's called Ayus, or Savour Island. And if you cut it along its long spine, one half of the island is divided into about 3,000 postage-sized pieces of real estate, some of the most expensive real estate in the world. This is called the Hawaii of British Columbia. It has long, long, long white beaches. And the other half still belongs to my territory. It's completely undeveloped. There isn't even a clearing for you to put your tent. And to me, it's a perfect symbol of Canada and Indigenous people. We share an island. You'd think that we would share the water table and the resources. And if they put a clinic here on this island, which side would that clinic go on? And do the people cross over from one side to the other? Can we as Indigenous people go to the side where there are beach houses and eat food on the beach? Can we walk through people's yards? And I think for the white homeowners, they're largely white, they feel nervous about crossing over into our territory and, you know, walking along the beach. They think, because actually it used to be illegal. It was literally illegal in Canada for us to cross over into each other's territory. No wonder people are historically nervous about it. As in, First Nations people were not allowed to leave their reserve without a pass, and before, white people were not allowed on reserve after dark. You could be jailed for it. And that was for many generations before those laws were changed. So what is two-spiritedness? So someone may identify as two-spirited because of their sexual orientation and or their gender, and that traditionally, two-spirited people held very important roles in our society, or they could hold very important roles in our society as healers, or as medicine people, or as leaders. They weren't considered odd, they were considered gifts because they could cross over. They could be warm and nurturing, or they could be deadly warriors, or they could be both. The most important part about a two-spirited identity is it goes beyond the usual gay, lesbian, bi, trans definitions in that it's within a cultural context, within an Indigenous context. And it's also partly about decolonizing the idea of being gay, lesbian, bi, or trans. Here are my middle sons and my father. I just want to tell a story. So as I said, my sons' mothers are lesbians. My middle sons, their mothers are white. My father said, I want all my grandsons to visit and they can come and hunt and fish with me for a while. He's 79 now. He wanted them to come and visit and to hunt. And so I relayed this to their mothers and I said, Dad, their grandfathers asked for them. And one of them said, you want us to send our beautiful sons into weather with an old man with knives and guns on the ocean and into the forest? No. And we're their mothers, and we decide. And so we had a clash, and it was interesting because the negotiation between gay men and lesbians about parentage, I think, is a complex one, and I'm not sure how much it's been discussed here at this forum. Definitely, just to put it in a nutshell, of course, the experiences of lesbians and gay men as mothers and fathers is completely different. But I dislike being always the second-class parent and being disparaged by their mothers as not being able to contribute or being that wasn't part of the deal for you to contribute to their well-being. Even though I thought we had discussed every possibility, and I said, well, these children are half First Nations, and you must honor that. I don't wish for them to grow up without their cultural or ethnic identity. And we're still working that out. And I hope that in dialogue with our, I want to call them colleagues, our neighbors, our partners, our allies, that we can have these frank discussions around our families and these new configurations. So, I work now for the First Nations Health Authority. The only thing that you need to see in this slide is that we have a number of agreements with the province of BC and the federal government to look at First Nations health. I would dare say that the surveillance or the watching over of First Nations people's health has been remiss. Not enough people were worried about it, and there wasn't really a lot of formal engagement to make sure that Aboriginal people's outcomes were equal to other residents of Canada or British Columbia. Imagine if we, as gay men, had agreements or had formal agreement or formal commitment to engage us in health planning. Imagine if we were part of Canada's planning for our own well-being. Imagine if there was more investment in our health. Imagine if Canada cared whether we lived or died, or that we were happy and that we did well. And I think that they do invest in us somewhat, but imagine if we were planning, and some of us are coming together to talk about what would a gay, lesbian, bi, trans, queer, two-spirited health plan look like for BC. So we've started it. And firmly, when we spoke to we've spoken to tens of thousands of First Nations people, we said, what would you like in your healthcare system? And they described this. Almost to a person, they said, we want a holistic approach to health. The mind and the body and the spirit are intertwined. And if you're only looking after our bodies, like the old health system or the current health system, then you fail. And the way that we grow up, we incorporate a holistic and a traditional approach to our well-being, and we don't want to give that up in order to enroll in the greater society. And it was very interesting to me because, of course, you know, as someone who's gay in his bones, I understood this to be true. I dislike passing as straight. I don't want to give up my gay identity in order to participate in greater society. I don't want to be in the closet and not be out in order to sit with a group of highly placed physicians in order to do planning. And so I think you understand where I'm going with this. How can we celebrate our queerness or our gayness and participate in dominant culture and demand, ask for, equality in health outcomes and equal investment in our health and well-being as other British Columbians and Canadians? As part of my job, I was the former Deputy Provincial Health Officer, and I'm so glad you're looking at the Provincial Health Officer's report. I'd like to think that my presence in the office really prompted my boss to look at men's health and gay men's health. I can't really take credit for it. I just wish I could. But one of the things that we were doing was monitoring the health of First Nations people, and one of our most dramatic health indicator outcomes that we saw was around HIV-related mortality. This is HIV-related mortality to 2006. Sorry it's not updated. Actually, I'm going to show you some HIV-related data after this. But HIV-related mortality from 1993 on this axis to 2006 at that axis, there are all the different points of HIV-related mortality. The bottom line is other residents of BC. The top deep blue line is our First Nations people with HIV. And you can see around 1997, about 1/3 of the way down, that HIV-related mortality for other residents of BC dropped and flatlined. This is with the introduction of highly active antiretroviral therapy. For First Nations people with HIV, their HIV-related mortality just kept going up and up and up. And it raised to us, in a Canadian and British Columbia context where we have world-class care, and where we have phenomenal medical interventions, why were those magic pills and magic bullets not reaching First Nations mouths? What was happening? And so we had to supposition what were the obstacles. And of course, people say, well, you know, were they physical, were they geographic? Was it just a question of distance? And we said, yeah, maybe. But probably there are other obstacles to care for First Nations people that need to be considered, like social isolation. And I'm putting these up here not so that you learn more about the obstacles to Indigenous health, but to obstacles to our health, because these, of course, apply to us as gay men. Social isolation, you know, where we're not connected to greater society, we're not connected to the social net, or we're not connected to a health system that may support us. A lack of confidence in the system, that it's unable to address us in a respectful and open manner. A lack of confidence in personnel, that they can engage with us in a professional manner that enables us to discuss openly our health concerns. Previous experiences where maybe we had a loss of, not a loss of face, a loss of dignity. You know, where you're speaking to a healthcare provider, they're rude, and they, for instance, I remember one of them saying to me, "You have 6 kids and you're not married?" And I thought, oh my gosh, that is so funny. to them, you know, to that healthcare worker, they thought I should be married to the mothers of my children. Previous experiences, compelling distractions. Are there distractions that keep us from wellness? The social determinants of health, which I heard you talking about earlier. Health literacy, as in health knowledge. When I came to Vancouver as a medical resident, I was actually part of a study here in Vancouver that was tracking young gay men to see which of them were seroconverting and what were the commonalities of those young gay men, who was seroconverting and who wasn't. And the outcome of that study was that, you know, which has been shown all over the world over and over again, is that young gay men who have fewer options, as in if they have lower educational attainment, if they're poorer, if they have poorer housing, they get HIV quicker than other gay men who are more highly educated, who are wealthier, who have economic possibilities and educational opportunities. So it's very real. Your knowledge can affect your body. We also had issues of privacy. We had historical institutional neglect, in that historically parts of society didn't care whether we lived or died, and we expected that. Stigmatization, we're the gay guy. Har har. Microaggressions, when people are mildly aggressive towards us. Microaggression, as an Indigenous person, let me see the last one I heard. Oh, you're First Nations, you guys get everything for free, right? I'm trying to think of a microaggression for a gay man. I think of a funny one. Yeah, I can think of one. So y'all can just yell it out if you can think of one. Caregiver ignorance of our cultural and historical differences. Racism. Racism is really quite interesting. Part of my job is to go around the province speaking to medical staff to assess certain incidents, like complaints of racism, and to see that medical professionals are doing the job that they're being paid to do. So I can say, get a complaint about racism in a merge in a small town, and I get there and I meet with their medical director or their clinical supervisor and say, hey, so tell me about the services you have here. And then they describe them, and then I say, oh, and I have this complaint of a racist encounter between a community member and one of your staff. And they always say, no way, never, not in my hospital, not in my department. And I can extrapolate that to homophobic experiences, that if I ever received a complaint about someone being homophobic towards a patient or a client, and I went to the director, the medical director, and said, this is what I've heard, that their initial response would be to deny it. No, my staff are not like that. And I at the beginning of my work, several years ago, in reviewing these kinds of files, I would get very angry, because I would think that all of these physicians are generally well-educated and generally fairly bright, all of them denying that racism or homophobia existed. I wanted to say, do you think I'm hallucinating? Like, why would you not think, how naive can you be that you think racism doesn't exist here, or racism? And it seemed to say to me, racism doesn't exist in Canada, and ditto with homophobia. So, let's talk about HIV. Here's some current data that we got from the Center for Excellence, HIV/AIDS. We looked at First Nations HIV-related outcomes. We looked at 1,433 Aboriginal people with HIV who were on treatment. Of those 1,433 cases, 917 were still alive, and 770 were currently on treatment. I'm just going to whip through these. So, just looking at the far column, which is suppressed overall. So this is a First Nations people, that far cluster of 3, First Nations people with HIV who are suppressed overall. The green column is the 2007 figure, which is just over 30%. 2009 in blue is just next to it, and then the column in column in yellow for 2011, still just under 40%. Small increases, though, from 2007 to 2011. Just under 40% of First Nations people with HIV who were on treatment had full viral suppression. So, how is that? So the Cascade amongst First Nations persons for 2011, again, just looking at the far column for suppressed overall. In green are non-First Nations people being treated for 2011, compared to First Nations people suppressed overall 2011, and you see the disparity. Significant. By gender, females in orange, males in blue. These are for First Nations people. There's no comparison to non-First Nations people. And this is just to show how close the columns are. Amongst other residents of BC with HIV, men far overrepresent women in our population. There are a goodly number of First Nations women with HIV. That's all I'm trying to point out in these slides, and I am just whipping through them because our health is much more than just HIV, so I don't want to spend a lot of time here. So this is a cascade among First Nations people by Select Health Authority, in that we wanted to see if our First Nations persons with HIV population was doing better, closer to tertiary care, like closer to Vancouver, and were they doing worse in the north, where they might be further away from service. And we were wanting to see if, say, in interior health, which is the middle column, where you might consider them more suburban, were they failing because they were falling in between the cracks? Were they failing because they weren't a rural effort? Were they failing because they weren't an urban effort? We weren't sure. So we put them all there. And you can see that in the green columns, Vancouver coastal health, that viral suppression overall is much better than compared to northern, which is in blue. And in interior health, First Nations people with HIV were kind of intermediate compared to Vancouver coastal and in northern. So this tells us that our efforts in Vancouver coastal, had some success, and that we needed to focus a bit more in the north to get those outcomes to be a little more comparable. This is an overall overview of risk profile among First Nations, and the green part of the pie chart are IV drug users. So a good portion of our population with HIV are IVD users. And that means that our efforts to reach them with wraparound care and our treatment needs to have a particular sway. I'm just going to skip ahead. All right. So this is a cascade of care for MSMs in 2015. Really, I just want to show you again the very far column, which is suppressed viral load overall. And you can see that of the percentage of diagnosis, the outcomes are around 72%. 72% of MSMs diagnosed are suppressed, virally suppressed overall. And if we compare that, let's just ignore the middle column. For First Nations people, our suppressed overall is 31%. So MSMs, 72% suppressed overall. For First Nations, 31% suppressed overall. Not a great success story from our point of view. There's much more work that needs to be done. These figures just came forward and are profoundly disturbing to me, and I take this rather personally, and we are making a plan to address these figures. This is me and my husband. I see Dr. Coleman here. Bill must remember when I was on a brochure like 20 years ago, and they were saying, "Oh, it's so nice to see models who aren't young and hot in your HIV campaign." Thank goodness. And this is to promote testing, or to normalize testing for First Nations people. There are actually a series of posters with numbers of different kinds of couples saying that couples can test. It's actually a really good thing. So we are, of course, much more than just our HIV status and HIV-related health. We should, in our planning, look at issues of mental health. We should, of course, look at issues around substance use and abuse. We should look at tobacco use, nutrition and weight, physical activity, body image, and many, many others, including sexually transmitted infections, the issues around bullying, violence or interpersonal violence within a relationship, self-harm, homophobia and how it affects our health and well-being, cancer, of course, and also the social determinants of health, our self-rated health status, as in, for some people, they're not related. The worried well the idea of the worried well typifies this, that you're physically well, but you're not well, you don't feel well in your mind. Or vice versa, you can be unwell, but happy. So where do we fit? How do we rate our own health and well-being? Our cultural health and well-being, and for those of you who were around in the 80s, I miss the 80s. I miss the excitement of the 80s very, very much. And I really wanted to fit a picture of a drag queen here in my slide deck to show that the power of our culture and our sense of fun and our sense of risque. But I didn't have time to drop it in. Because certainly with First Nations, and a First Nations approach to health, we try not to be conservative and we try not to dumb down our cultural approach. It doesn't help. In fact, we should be embracing the entirety of our cultures and celebrate that. And so the joyfulness of gay men's culture, I think, needs to be part of our planning. So, at the First Nations Health Authority, we know that we're not the be-all and end-all of First Nations health. We're just a partner. First Nations health belongs to First Nations people, just like gay men's health belongs to gay men. And any health planning for gay men, or say a gay men's health service organization, won't be the center of gay men's health and wellness. Again, that health and wellness centers around the person. That we live the wellness model. We live for wellness, not just looking at disease, and that we are champions for health and wellness. We speak about wellness constantly. We ask others about their health and wellness. We encourage their health and wellness, and we actually help as neighbors who deliver care to our gay brothers. We participate in their health and well-being. So we're not just there when the going gets tough. We actually, as good neighbors, share health and wellness with each other as a family. That we commit to our youth. And this is a very interesting perspective. When I was a young gay man, I didn't think a lot about a generational approach. I didn't think about the health and wellness of men who were in their 30s or in their 40s or their 60s or their 80s. I really only thought of gay men as being, men who were the same age as me. And of course, wellness for a 20-year-old is different than the wellness for an 80-year-old. So that kind of life stage planning. And of course, my family is young. And so planning isn't just for 20-year-olds and older. It isn't just for men. Planning for gay men and their families must also include children as well. So, as a medical student, I really thought that people's wellness was decided by their proximity to a physician. Wow, that was a ridiculous thought. If you ask people what keeps you well, and if I asked you what keeps you well, you would mention very large ideas like love and relationship, family, opportunity, maybe even money or jobs, beauty, art, fashion, film, music, the pursuit of pleasure, parties, sex. You might mention safety or equality. It might be around opportunities for knowledge. You might mention fairness or recreation, like a recreation center, an aquatic center, a place where gay, lesbian arts happen. Certainty. That safety for generations is part of our planning. And the World Health Organization looks at gay, lesbian, bi, trans health as well. Significant challenges exist for the LGBT population, including a higher prevalence of HIV/AIDS, institutionalized prejudice, social exclusion, and anti-homosexual hatred and violence, widespread stigmatization and ignorance in mainstream society and within health systems about different gender identities, the requirement in some countries to report LGBT citizens to authorities, and a lack of curricula and health standards throughout the globe to create adequate training of healthcare professionals to care for LGBT people. The good news is that Canadian attitudes and opinions are changing. A recent national study showed that 71% of Canadians have little tendency to stigmatize. Oh, my notes are not showing. How do I finish that sentence? Oh, we'll just make it up. 71% of Canadians have little tendency to stigmatize their gay brothers. course, we as healthcare workers and as workers who support care, as in not all people who support health and well-being and care in communities are healthcare workers. And we who support the health and well-being of our communities need to continue to do our part to destigmatize our community, including anyone who's living with HIV/AIDS. In my work, I look after First Nations governance, as in who's in charge of what within our converging health systems. So who's in charge of First Nations cancers? So I sit with governance, thank you. I sit with governance to talk about First Nations cancers. And in that regard, the BC Cancer Agency, who looks after all British Columbians with cancer, is doing a great job. We don't want to create a First Nations cancer center. Clearly the lead is the province or the cancer center. But in other places, it's a little less clear who's in charge of what. And I remember at one of the tables I was at, we were talking about a First Nations baby who had died, and we wished for that baby to be returned in a timely manner. And the chief coroner said to us, well, you know, by law, by the BC coroner's law, I'm allowed to keep that baby's body for as long as reasonable, like under 2 months, in order to determine a cause of death. And I can remove parts of that baby's body that will then be returned to you to be reinterred with, you know, after the rest of the body has been returned to you. And the chief said, we know you think you're in charge, but we think that's our baby. And it just really crystallized to me the patient voice and our voice in the face of government and law and policy, that these are our bodies, this is our well-being. We must have a say, we do have a say, and we must ask for a better service. And in this case, they were asking for a better service, you know, where our body wasn't experiencing such invasive procedures, and where the bodies was returned intact and in a timely fashion. And I want to finish with the idea of a gardener's tale. The gardener notices that pink flowers flourish while red flowers languish, but has forgotten her original decision to separate the seeds into 2 types of soil, one rich and in one poor. And instead she thinks, I was right to prefer pink over red because the pink have grown taller and stronger. So we are the gardeners, I'll be clear, we are the gardeners, and we must make things right in our garden for all the flowers. And as my elder says, our job is not to be important people with lots of letters behind our names. Our job is to be the best human being possible. And in order to accomplish that, sometimes we need to do things in a slightly different way. And I showed this to an elder, and she said, oh yeah, the male eagle flies upside down to have sex. It wasn't quite what I originally intended the slide for. But I find it interesting to know that the male eagle is always the bottom. Thank you.